Thank you very much. So good afternoon, everyone. Our topic for the didactic today is another newly approved medication. So this is an overview of Lybalvi. Yes, it is a new medication. Unfortunately, it is not as novel as it may seem. So it's a combination product of the Olanzapine and Samidorphan. So we're going to talk a little bit about the pharmacologic rationale. So why did they link these two medications up? We're going to look at some of the pharmacokinetic considerations. So yes, it is a new medication. So what are some things we need to think about, but it's not, again, nearly as novel as we would like. And then we're going to look at the clinical trial data. So both looking at the efficacy as well as the tolerability and safety data for the combination. So the Lybalvi, it is Olanzapine, Samidorphan in a fixed combination. The Olanzapine is the only one that changes in the dosing. It's available in tablets. But the Samidorphan is 10 milligrams regardless of the strength that you choose. The Olanzapine is available in 5, 10, 15, and 20. So we can titrate according to the Olanzapine preparation. It's officially approved right now for the treatment in adults with schizophrenia, as well as those with bipolar 1 disorder. So it was approved for 3 different specific indications for bipolar disorder. So the acute treatment of patients with manic or mixed episodes, it got approval both as monotherapy as well as adjunctive therapy if it's used in conjunction with lithium or a valproic acid derivative. And then it also got approval for maintenance in patients who have bipolar 1 disorder. So it ended up with a few different indications. They are currently enrolling patients, excuse me, in clinical trials to expand the indication. So they're looking to expand the indication for bipolar disorder into adolescent patients, as well as looking at some additional indications for binge eating disorder, and they're looking at oppositional defiant disorder. They're looking at a couple of different indications for pediatric and adolescent patients. In terms of dosing, they do recommend a slight titration. This came directly from the prescribing information. For schizophrenia, they did recommend a slightly lower initial dose with 5 to 10 milligrams of the Olanzapine initially, titrating up anywhere from 10 to 20 milligrams based on response of the patient. For the bipolar disorder, the acute monotherapy, they recommend starting at 10 or 15. If it's being used adjunctively, they do recommend starting with the 10 milligrams of the Olanzapine, so the 10-10 combination. And then for each of them, the titration is again based on response and can be titrated up to a maximum of 20 milligrams of Olanzapine total. So they did allow for a little bit of flexibility within their dosing as much as they could with the fixed combinations. In terms of pharmacology, I'm not going to spend as much time on the Olanzapine. So Olanzapine is a dopamine 2 antagonist and the serotonin 2, mainly the 2A antagonist. So blocking the dopamine receptors has been demonstrated to reduce psychosis. It also can assist with some of the symptoms we see in bipolar disorder. The serotonin antagonism can also help with some of the signaling, helping control some of the psychosis, but potentially not exacerbating some of the negative symptoms by allowing some additional dopamine and some of our dopaminergic pathways. The new addition is the Samidorphan. So this medication has been passed around a little bit, looking for a specific home. Many of you may have heard of this in some of the other formats because this was used in a couple different combinations. They were looking at it for treatment of depression, which never got an official indication. They also were then looking at it for treatment for weight loss and prevention of weight gain with antipsychotic medications. That's really where this came in. So not necessarily that it's adding additional benefit, in terms of being an antipsychotic or in terms of being an anti-manic type preparation, but more to assist with the management of the weight gain that's seen with the olanzapine. So really being added on board to assist with the tolerability piece and not necessarily boost the benefit of the efficacy of the olanzapine. And I will back that up with some of the clinical trials we'll look at here in just a second. From a pharmacokinetic standpoint, we're looking at a product that has 2 active ingredients. So when they reported it out, they reported out for both the Samidorphan and for the olanzapine. Both are well absorbed orally, which is nice. They are absorbed relatively quickly. We see peak concentrations with the Samidorphan earlier than what we see with the olanzapine, and its half-life is quite a bit shorter. So it's not going to last quite as long as what we see with the olanzapine. Because it's for side effect management, that doesn't look to be problematic, but just something to keep in mind. Protein binding, olanzapine's pretty protein bound, but it still gets to where it needs to go in the CNS to be able to have its actions. And it is hepatically metabolized. So we see the cytochrome P450 enzymes 1A2 is primarily involved with the metabolism of olanzapine. 3A4 is primarily involved with the metabolism of the Samidorphan. Because they're looking at the Samidorphan is in addition to control the weight gain, while the 3A4 does open itself up for a lot of drug interactions. It's really just more recommended to look at tolerability. So if we have a lot of the inducers or inhibitors of 3A4, it's more just watching, are we starting to see more weight gain than what we would expect with this particular preparation. So it doesn't look quite as problematic as if the primary ingredient was a 3A4 substrate. The other non-cytochrome P450 enzyme, the UGT 1A4, is also involved primarily with the metabolism of olanzapine. So from a drug interaction standpoint, not really new interactions to be concerned about. Aromatic hydrocarbons with the from tobacco smoking are still a concern. With the olanzapine, we see a couple other agents, fluvoxamine being one of them, as being something we want to keep in mind, but for the most part, not as much of a concern as what we may see with some other products. Half-lives are listed here. In general, it's going to take about a week to get to steady state. So that means when we start the medication, it's going to take a week to see how the patient's going to be able to tolerate those serum concentrations, because they'll keep building for the full week. And then it may take a little bit of time to be able to see what the true efficacy is going to be of that particular dose. Not much different than what we see with the olanzapine. As we look at the clinical data, they actually saw a pretty good separation from placebo relatively quickly. So just something to keep in mind from a tolerability perspective, if we are titrating the dose up, that it'll probably take a week to be able to really truly see how a patient can tolerate the new dose. Similar to the other products, eliminated both in the urine as well as in the feces. There's not really a huge issue if a patient has renal dysfunction. It's a lot more dose adjusted based on tolerability. So not too much new on the pharmacokinetic side of things, nor on the cautions or contraindications side of things. So because it is a product that contains the olanzapine, it carries some of the same warnings that we see with the other antipsychotic medications. The main cautions are in elderly patients who have dementia-related psychosis. So they do see increased mortality with this patient population, as well as increases in the cerebrovascular events. Not unique or specific to this population, but more of a class warning that's gone out. With the Samidorphan, there is, and with this caution comes neuroleptic malignant syndrome, worries about things like tardive dyskinesia, the metabolic complications, all of that stuff comes as well, but it really hadn't been elevated necessarily to be a main specific caution that's listed in the prescribing information. It's more kind of packaged together as some of the concerning serious adverse effects that we see. The unique caution that was added to this preparation is an increased risk of patients being vulnerable to opioid overdose. So we're going to talk about how the Samidorphan works. We did talk about how the Samidorphan works. So antagonist to the mu receptor, and it's a partial agonist at both delta and kappa receptors. Because it's an antagonist at the mu receptor, there is a possibility that patients may try to ingest higher doses of opiates to overcome this degree of antagonism. That would lead them at a high risk for overdose if they continue to take relatively large doses. The half-life of the Samidorphan is only 11 hours. That means within a couple days, most of it would be gone. It also means that those receptors might be a little bit more sensitive. So there is a precaution there. In all of the clinical trials we're gonna look at, they all excluded patients who were using opioids at the same time. So they specifically added verbiage into the labeling information that says that it can't be used, excuse me, within 7 days of short-acting opioid use or within 14 days of long-acting opioid use. Now, does that mean that they will never be used in combination together? Probably not, but at least according to the labeling, that is the concern that they included, because that was how they set up the clinical trials from a safety perspective. They didn't want patients going into withdrawal, which is a risk if they have been chronically using opioids and then they start taking the combination product. So that's kind of the new piece to this preparation. So how does it look? Is it anything different? Well, with the olanzapine, we would expect efficacy for both schizophrenia and for bipolar disorder. In terms of the clinical trials for schizophrenia, so they have two main clinical trials that got them the approval by the FDA, and then they had an open label extension. Both of the clinical trials enrolled patients who were moderately ill with schizophrenia. They tried to exclude patients who had other diagnoses, but they weren't quite as strict because they knew they were going after the diagnosis of bipolar disorder as well. They included 3 different groups. So they included placebo, an olanzapine group, as well as the combination group. They did this specifically so that they could compare some of the adverse effects, because they're looking for this to be as effective as the olanzapine alone, but to not have quite as much on the side effect side, especially with the metabolic adverse effects. So what they saw, this came from their main website. Most of the clinical trial data has not been released yet. So it took some digging to find the actual publications, and our library does not have them. So I did request them. I didn't get them in time to be able to include them myself here, so I had to borrow the results that they had posted. They were looking from a primary outcome standpoint at changes in the PANSS score. So they saw changes within the first week of starting to pull away from the placebo. They saw significant improvement by week 2. The olanzapine and the combination group both were significantly had a significantly greater change from baseline compared to the placebo, but there wasn't a difference between the 2 groups. So the olanzapine and the olanzapine Samidorphan group both were found to be equally effective. And it was equally effective in both groups. So both the, they called them Enlighten 1 and Enlighten 2. So in both of those groups, they saw the same change. With the Enlighten 2 group and the Enlighten 1, they allowed patients the option to have an open label continuation. So this is just the results from one of the open label continuations, and they saw that patients continued to do well as long as they stayed on the medication. They did have quite a few dropouts in all of the groups, but for the most part, they didn't see too much additional change in terms of efficacy long-term. We saw them trending down, which is what we would expect if patients who are moderately ill with schizophrenia continue their antipsychotic. So less likely to relapse, less likely to have recurrence of symptoms. So that seems to bode well that this works very similarly to what we would expect, because it does include the olanzapine. How about for the bipolar disorder? I couldn't find the actual results in any of the trials. So there's about 4 or 5 publications that are out there that are reviews, but all of the reviews only contain a narrative summary. The prescribing information only contains a narrative summary. So the amount of change that we have on some of the rating scales, like the Young Mania rating scale, which was the primary outcome for both the monotherapy and the adjunctive therapy trials, that's not available yet. I did request the one clinical trial that I think includes this, but I just haven't received it yet. What I do know is they had to do they did 2 monotherapy trials. Both were relatively short term. So a 3-week trial and a 4-week trial. They included an olanzapine group, a placebo group, as well as a combination group. Excuse me, one of the bipolar trials had quite a significant placebo response, but despite that, the change from baseline was looked at as the primary outcome, and there was a significant change from baseline for the combination group. There was for the placebo group too, so there was quite a bit of placebo response, but because the change was in the combination group, they were still able to get that indication. For the adjunctive therapy group, they did slightly longer trials. So looking at 6 weeks when it was added on to lithium or valproate, they did do some conservative dosing with both the lithium and the valproate, but they saw significant improvement from baseline to endpoint at the end of those 6 weeks. So that's how they got both of those indications. In terms of maintenance, so these are only bipolar 1 patients that were included. If they had responded to olanzapine, they were able, and that was in a 2-week open label trial, they were able to continue on the product, and they were just following them to how long until they had 50% discontinue. So when they looked at that with the combination group versus the placebo group, patients on the combination group lasted longer. So they didn't drop out because of tolerability or because of lack of efficacy until almost twice as long as what they saw in the placebo group. So 50% of the placebo group was gone by day 23, and it took until just about day 50 to day 59 to get to 50%. So they were almost doubling the amount of time there. With that being said, 2 months is still not great for maintenance treatment for bipolar disorder. Some of our longer trials only go 6 months, so this was better than nothing, but just kind of something to keep in mind that it's not really great data. So efficacy-wise, yes, it works. It works compared to placebo, but what about side effects? So side effects, exactly what we would expect with the olanzapine. Samidorphan, for the most part, tends to have some sedation, some dry mouth, some headache. Those are the adverse effects that tend to be most frequently reported, and we saw them rolled in here. We still see some of the metabolic effects with the weight increase being 19%. So almost 1 in 5 of the patients in the clinical trials had some degree of weight gain. It was 3% for the elevation in blood insulin. So it's thought that the delta and kappa receptors actually help with some of the metabolic signaling. So they can help with satiety. They may also be able to help with insulin sensitization. So the thought is maybe we don't see quite as much of an increase here because of that additional samidorphan. So side effects, really what we were anticipating. Not a lot of movement disorders that were noted here, but in most of the trials, they were relatively short-term trials. So maybe not a surprise that we didn't capture them. It's probably not that they're not there, they just weren't reported. Zooming in specifically on the metabolic adverse effects, because that's where this is supposed to make a difference. For the combination product, patients who had a normal glucose at baseline who ended up with a high glucose, so over 126 milligrams per deciliter at endpoint, was 12% for the combination group. Changes in hemoglobin A1C, so sugar that's in your blood, actually attaches to the hemoglobin in your blood, and we can measure, and it gives us really a picture of where your sugar has been over a 90-day, like a 3-month window. So going from normal to impaired, so meaning it's been running high, but not super, super high, 42% of the patients were in that category. Those who went normal to high, so they were over 6 or 6.5, depending on what the threshold was for the clinical trial, was only 0.5%. Why does that make a difference? Because if the hemoglobin A1C is impaired, that may mean that we can make some interventions to prevent them from developing diabetes. Although it's 42% and almost all of these trials were less than 90 days. So that is still something that we want to keep in mind. It doesn't look like it's completely reversing the trend, even though the percent that went to high was only 0.5. That may be a result of only having some of the patients in a trial for 3 weeks. Triglycerides going from normal to high, so over, I believe their threshold was over 200, was 14%, and those that had weight gain, so thought to be more than 7% gain from their baseline, was about 1/4 of the patients. So we still saw some significant metabolic changes. When they looked at it compared to olanzapine alone, they did, for the most part, see a difference. So in the Enlighten 1, the percentages actually looked a little bit higher for the combination group versus for the olanzapine group, and both were higher than placebo. In the Enlighten 2, they looked at those that gained at least 7% or those that gained 10% or more from baseline. And in each instance, the combination group was less than the olanzapine. That's pretty consistent with what they saw in some of the pilot trials that led them to get to phase 3 clinical trials. So the thought is that these patients still gain weight, but they tend to gain it early in treatment. They don't tend to gain as much, nor do they continue to gain as long as they're on therapy, which is what happens to some patients who are on olanzapine. So really, they're looking to position this product in a way that they can expand the use of olanzapine in patients who are gaining weight once they're on it. So that really is the target population that they're looking at. It doesn't bring those numbers to 0. And if we were to compare them to some of the other second generation agents, they probably still run a little high, even though they're different populations. But it may address some of the concerns that some patients may have, or the hesitation that they have about using an olanzapine product and starting to gain weight. So with that, I will stop my share.